Hi, it is 6 p.m. in Paris, 5 p.m. in Cardiff, Belfast, and London. And it is my great pleasure to welcome you all to this new broadcast as part of the ICH for Nurses series. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it is my great pleasure and privilege to moderate this roundtable discussion today dedicated to nursing care at the era of modern therapy for multiple myeloma. As you may know, the ICH for Nurses initiative was launched more than a year ago, and since it is proving to be a great success. The audience is growing, and the topics are becoming more and more diverse. And in order to address and discuss this topic, I have the great honor to have three distinguished guests. And by alphabetical order, I have Dr. Ceri Bygrave, who is a consultant hematologist in Cardiff in the UK, but also she is the chair of the UK Myeloma Society. So very timely hat for our discussion today. It is also my pleasure to have Jackie Quinn, who is a myeloma clinical nurse specialist in Belfast. And she is a chair of the UK Multiple Myeloma Society Nursing Group. And last but not least, I have we have with us Dr. Emma Williams, who's a senior clinical trial manager at the Cardiff Hematology Department. And her focus has been multiple myeloma for the last 10 years or so. So thank you all for joining. Welcome, and thank you for dedicating some time to this activity. My first question is to you, Ceri, because obviously people may wonder why we are focusing today on nursing care and modern myeloma. Why not sickle cell, or why not another disease? And I thought maybe in order to set the stage for our discussion, if you can highlight some of the latest advances we've seen in myeloma therapy, and then we'll try to link this. Why do we need the contribution of our nurses colleagues?
Sure. So thank you, Mohammed, and thank you to the ICH for inviting us this evening to talk about nursing care in myeloma. It's a great topic, and as you said, very timely. I think to set the scene, so I've been a consultant for almost 10 years, and my experience is that when I started, there was no dedicated myeloma clinical nurse specialist in the large teaching hospital where I work. The only CNS that we had was actually shared with the lymphoma team. And that's a huge portfolio for one individual. And fortunately, over time, we have now gained not one, but two clinical nurse specialists dedicated to myeloma. And we have a whole team on the trial side of things, which Emma helps to manage, helping support our patients on trials. And that's a necessity. And it's a necessity of the treatment developments that you referenced, and the fact that these are a very complex polysymptomatic group of patients living with a chronic malignancy. And I'm sure most of us know that myeloma is a malignancy that comes with a lot of baggage. Unfortunately, we still have to tell our patients at the beginning that it's not curable. But at the same time, one of the nice things that we can tell them is that now many patients actually survive for more than 5 years, and many actually survive for more than 10 years. But the term that I always use is it's a marathon, not a sprint. And we know that actually many of these patients might spend a lot, some, all of that time on treatment, on chemotherapy. And over the last 10 to 15 years, we've moved from a situation where all we had to offer people was, for example, simple tablet-based chemotherapy, steroids, alkylators, that kind of thing, into the era of novel agents, which we all know, and now into the era of immunotherapy. And it's great. And that's what has led to a lot of these changes and a lot of this increased life expectancy. But again, that doesn't come for free. And so the effect on the patient of living with this disease and living with the need to be on treatment for a long time requires a whole team. This is not something that a medic could ever manage on their own. It's also not something that a nurse could manage on their own or a pharmacist could manage on their own. We are a team, and we support each other and we support the patient. And so I think what hopefully we can get into over the course of this discussion is how much the role of the myeloma nurse has actually grown and changed during that period of time to reflect everything else that's been happening in myeloma care. And I'm sure Jackie and Emma would be willing to share their own experience of actually doing this kind of work. But we now have nurse-led treatment clinics, or we have nurse-led clinical trials. We have nurse principal investigators or even chief investigators on studies. And that's something that probably none of us would have imagined 10 years ago. But not only is it a necessity to help the patient live with this disease, it's just a huge asset for the profession and the service that we can actually now do that. And not everything is left to medics, because, you know, we have some skills, but we don't have all the skills. So that would be my assessment, really. It's living with this chronic disease and living well.
Super. This is really a great summary to the point, and I agree with you. The advent of monoclonal antibodies and the first in class were the anti-CD38. I think it has been a turning point with daratumumab, isatuximab more recently, and then we've seen the bispecific antibodies, teclistamab, elranatamab, and now CAR T cells, and there's more yet to come. So now maybe I can ask both of you, Emma and Jackie, and whoever wishes to start. Why do you believe, I mean, Ceri gave her perspective. Why do you believe from the other side, from the nursing side, we need more and more such a close cooperation between nurses and physicians? I mean, it's a generic, maybe a statement that we always need cooperation among all professionals. But here in this specific situation of chronic disease, patient being followed over many years, highly effective treatment, but probably some side effects to deal with. I don't know who wants to start. Jackie?
Um, Good evening, everybody. Yes, I came into the clinical nurse specialist role about 18 years ago, and the role has definitely evolved. With all these new treatments, lots of patients that may have passed away earlier are now living for longer. So the sheer volume of patients and support required has grown. We are getting very successful at treating them. So clinic capacity issues arise both in our day unit and to have prescribers on the ground. So I found that my role has really evolved as a result. Initially, it was the psychological support, helping manage toxicities, but that has evolved to actually undertaking nurse prescribing role. So I have my own nurse-led treatment clinic, which is a SAC clinic. So that has helped with the service delivery of the treatments. And the other benefit I feel that patients get, I have been in post for quite a number of years. So I've seen folks from diagnosis right through to fourth, fifth plus line therapy. So I get to know them and their families actually very well, and then tailor managing their social issues, signposting to support that might be in the community, support that might be available in the hospital to our allied health professional colleagues. So again, it's acting as a key worker, supporting, coordinating care, helping them manage their medicines, helping direct them for financial support and aid, and also then signposting carers, getting to know their families very well, know what's very important to the individuals, and trying to provide a care plan that incorporates patients' needs and desires and what's important for them, that maybe they want to go and visit grandchildren, maybe they want to travel, folks who are maybe newly retired, they want to have a life as well as treatment. And if they're on treatment for long periods of time, it's trying to provide that support and put a program in place of care that delivers that. What do you think, Emma?
Definitely. So what I've noticed in my role as a research manager is the actual shift of treatments that we're given. So in the last 2 years, I would say, of managing clinical trials, the treatments have changed and transformed so much in that short time, just in 2 years of me managing the trial portfolio at Cardiff. But with that, not only is that changing in that picture, but the actual side effects are changing. So they obviously we're giving more tailored treatment now. So the treatments side effects are very different to what we used to see with conventional chemotherapy. So we need to be very much more aware of what the patients are having at all stages. So from a trial point of view, in Cardiff, we have disease-specific nurses. And we see that as the only way that we can give the continuity that we need to give. And working with the clinical team is really important that we're forecasting our clinical trials so that we're forecasting that when one is opening, when one is closing or coming to an end, that we've got another trial in place to give the patient, to offer them the best thing that we can offer them. So working alongside our clinical colleagues, and people in the clinic all the time is so important.
Ceri, do you agree? Is this the same way the doctors
Yeah,
view things?
I think it is the way we think. I think we have a duty of care to our patients to sort of meet their expectations. And we've seen increasing numbers of patients diagnosed at a younger age. Many people are still kidded into thinking that myeloma is a disease purely of the elderly. But sadly, in our practice, we have good numbers of patients in their 40s, 50s, and 60s who will still lose many years of their life to this disease. And as treatment evolves, patients are becoming more informed. They are certainly reading myeloma literature. They're asking about access to therapy. And obviously, that's something that is addressed in the medical clinic, but it's also something that can also come out through conversations that they have with their clinical nurse specialists as well. Communication and time is a key thing, really. And time again, we see that patients will divulge different bits of information to different members of the team. And that doesn't necessarily mean that any of us do it better or worse, but it just means you can't rely on only having one type of interaction. So Emma mentioned side effects. We all know that patients may be tempted to downplay side effects when they speak to medics, because they are worried that we might pause their treatment, reduce their dose, and that might lead to a change in efficacy. And obviously, I can understand that, because essentially living longer, getting the disease under control, not succumbing to disease-related comorbidity is obviously a huge thing. But at the same time, if they didn't have other outlets to perhaps share more of the finer detail of how they might be feeling living on long-term bispecific or post-CAR T, or some of the other things that you touched on, then there's a risk that they could actually come to some harm. So that's just an example of where this support network can be helpful.
No, thank you very much. I think it looks very clear. And by the way, I would kindly invite the participant. You can jump in and post your questions or your comments or your suggestions to our panelists. So, Jackie, Emma, let's dig a little bit deeper into this important role of the nurses in myeloma care. And I would like you to address some very specific tasks and missions which we believe are crucial for the, I would say, appropriate delivery of a given treatment, and of course the communication, etc. For instance, what are the different items where you believe your role is most important?
Well, I think it's developing a really close relationship with your patient and having a good relationship with the wider medical, nursing, allied health professional team. Because if a patient trusts you, they will share more information. It depends on who they spend most time with at a particular point, and that can be any of the team. And that we link together to share that communication that they've had with us. Basically, as you've said, Ceri, patients will share different pieces of information with all of us. And the other part is their family may notice before any of us and before the patient ever discloses. And if you have a good relationship with them, they may share, just side effects, toxicity, for all the reasons that Ceri has mentioned. They want full dose treatment, no matter how awful it is for them. And their family might say, well, this is the first day they've actually got out of bed. I have one elderly gentleman, he comes up to clinic wearing a suit and looks very well kept, and he hasn't been out of bed for the last month since we last seen him. So it's getting that type of information and developing those good relationships, knowing who in the family is looking after the patient and is in and out of the house and can actually give you those finer points. And then if we're looking at change in therapy, having that discussion, if it's disclosed to me, I would have a discussion with the hematologist that looks after the patient, so that, there's more than one voice and that the team work together really to try and get the best possible outcome for the patient. And again, involve the family and the patient in that discussion as well, so that they understand why decisions are made and help guide them in making probably the best choice for them.
I agree, Jackie. And I think that this is where nurse-led research really comes into play. So obviously a lot of conversations that we have as nurses are a very different type of conversation to what a doctor would have with their patient. And like you say, the nitty-gritty of their day-to-day lives can be really evident in our nurse consultations. So I think it's really important to have nurse-led studies, and this is why we advocate them in Cardiff and why Ceri is a big supporter of them, because it's not just about the treatments. You can give all the treatments you want to a patient, but if they haven't got the quality of life or the passion within their life to live a life with the condition, then you're in for trouble, and this is where the nurse-led studies can really look and delve deeper into that aspect of their lives. So I think having nurse-led portfolio, but a consultant portfolio as well, just adds a greater depth to what we're providing to the patient.
Excellent.
I very often just say to patients, the purpose of treatment is to give you a life, not to take it away from you. And I very often hear myself repeating that day after day.
Yeah.
So we have an important question here from the audience, and maybe Ceri, you can handle this, whether you can elaborate more into the role of nurses on shared decision making on treatment options, because obviously historically one would envision that this is a doctor in his office and then deciding on this and this, but we know very well these days it's about the multidisciplinary meeting. So can you elaborate a little bit on the specific role of nurses?
Sure. So I know, Mohammed, you have some familiarity with, for example, the way the UK treatment algorithm works. So, for example, if we consider second line treatment, in the UK currently we have at least 3 approved treatments that patients could have at second line. So there's KRD, carfilzomib, lenalidomide, dexamethasone. KD as a doublet without the lenalidomide, and DVD. So daratumumab, Velcade, and dexamethasone. And then obviously patients who've had a long PFS1 from a first transplant and who are younger and fitter can be eligible to go through a second procedure. But what we don't have is any head-to-head trials to tell us which one of those is the best option for any given patient. So, of course, we can quote the PFS from the approval studies. So the CASTR trial for DVD or the ASPIRE trial for KRD, we can quote that data. But how that matches up in the real world and how that fits with everything that Emma and Jackie have talked about individualizing therapy and making sure that we actually allow patients to make informed decisions that suit their lives is a different story. And so I think often the patient will quite rightly look to the medic to try and decode all of that to give them, our best estimate of which might be clinically more appropriate, but that's not the whole decision. One thing that we haven't mentioned, but I think is a big factor, is scheduling of treatment. And that is then linked to time away from work. It's linked to time off work. For example, if you were going to go through a second auto in second remission, those can be huge factors for patients, especially if they have financial worries, if they have carer responsibilities. All of that can be weighing on their mind when they come to clinic. And if they just sign up for the treatment which the doctor proposes as being best, you might not necessarily be covering off all of those important factors. So there's just one example of one line of therapy in the UK where we are continuously having to help patients find the treatment that suits them best. We lack real world data to actually individualize that as much as we would like to be able to in the clinical setting, but we do have the support of other team members that can help at least get the other holistic aspects of care right. And I think that's really important.
Can I ask a straightforward question to you, Jackie or Emma? Did it happen to you that the physicians decided on a given treatment and then you came back to the doctor and say, well, I know this patient and they will not be able to take this medication or to tolerate it, or even, actually it's too far from home, they're not willing to travel? Do you have these examples, Jackie?
Yeah. Northern Ireland, while a small place, there is quite a considerable distance for folks that may have to travel for treatment, particularly those that maybe are working or elderly folk where they might have to travel for a couple of hours to come for a treatment that can only be given here. We don't have a very good outreach service whereby it's local to home. So there are patients then who may live a distance, may not have the support of family or carers. And may not, there's some folks maybe have other issues, social issues, maybe can't read, can't manage their medication. And it is then maybe it's a dream to try and give them, yes, you would like to give them maybe an oral regime, but realistically, they're not going to adhere to that. They're not going to be compliant. So perhaps, given a regime whereby, yes, they can travel, but maybe less frequently, but at least we can actually administer treatment when they come to actually to the hospital here. So yes, I've had those discussions for all of those issues, and I have to be honest, I work very closely with my hematology colleagues, and they do take that into account. And it is bringing the patient into that conversation as well, that they understand why, you would be encouraging them in one direction and not another, to try and make things as straightforward, that they're compliant and that they're not getting toxicity from a treatment and not getting the benefit because they're taking it now and then or ad hoc, which isn't really the way you would like things to be done. And the other thing is those folks that live a distance away or maybe elderly, frailer, they're not going to ring your helpline. They're going to be the very folks that stay at home. Maybe nobody has gone in to see them from they last came to their hospital visit. So you would worry that toxicities and they become quite unwell at home and have no support and really come to harm. So those things would all come into the conversations that we would have and do it probably on a frequent basis. But it's just like routine practice that we talk about everybody now, just to look at the best regime that's available for them.
I think the other important thing to say about that, Mohammed, is that it's really important when any study comes through the department. At first instance, you know, there's a lot of science, there's a lot of excitement behind every study that comes through. But then my role as the research manager would be to home in on the protocol, the lab manual, to find out exactly what this means to the patient, what the travel requirements are, how long they're going to be in the hospital on day one of their visit, you know, all of these crucial time points, which necessarily other people wouldn't have thought of, that we really home in before we open any trial. And it's very much from a patient perspective and what suits them. And it can be, and working so closely with Ceri again, you know, we will have that open discussion. If she finds a patient that is potentially eligible, we'll have that dialogue of, you know, how far do they need to travel? We'll have all those conversations. So yeah, it's starting it from a very early stage in the process when a trial literally comes to the department. Really important.
Ceri?
Yeah, I think those are all great points. And I just wanted to come back to something Jackie touched on about compliance, and the role of compliance and the importance. So, Mohammed, you and I, as investigators, know that the drugs won't work as well as we want to if they're not taken as per the SPC or as per the schedule. And yet we also know that compliance in and out of research trials can be very variable. And again, that's something that patients may hold back from discussing openly with medics. But I certainly get a lot of information from my team about things that I really wish they would have found easier to share with me, and compliance and missing days of treatment, or, you know, any number of things that affect that can be highly relevant in the clinical arena.
Excellent. So I'm glad we touched base already several times on clinical trials, for instance, and obviously we owe a lot to clinical trials. And I take the opportunity to thank all the patients and families who participate to these trials, because first of all, they are giving us their trust, but second, they are also allowing to advance the field, and hopefully one day we will get a curative treatment to the majority of the patient. So here I'd like to ask you, Emma, first, and Jackie, and then Ceri, is about the specific role of the nurses for the monitoring during the treatment. Because I have in mind, I can give you now one example came to my mind, that I can remember immediately at least 3 patients I have included in 3 famous clinical trials, well known. One, the Maya trial, Dara, lenalidomide, dexamethasone. One, the IKEMA trial, and this lady was in the isatuximab, carfilzomib, dexamethasone arm. And more recently, I had a patient in the IMROSE trial, which was, by the way, communicated as being positive in a press release a couple of months ago, receiving isatuximab, bortezomib, lenalidomide, dexamethasone. I'm mentioning these 3 patients because actually they are still treated in these protocols for more than 5 years. So that's really, you know, a significant. And I must confess, although they've been treated for 5 years, most of the time they see the nurses. So how do you see these situations?
Well, it's just crucial, you know. We've found that in Cardiff that we've just got so many patients in follow-up, and I think when we first open a trial, it's all about the recruitment and getting the patient in and getting the trial open and started. But these patients are often in trials lifelong, and we form really, really close relationships with them. One thing we've had to do in Cardiff is open our own research clinic, which has been a new thing, but it's to ensure that we're, you know, we have time to spend with the patient, that we have time to relay any updates to the study protocol or any amendments, so that we've got time to consent and sit with them and do that, because it's all about the follow-up of these patients and, you know, and following them up and reporting, which we continue to do, you know, long after the study, on the clinical ground, that people stop hearing about it. We continue to follow those patients up, and we form such an important relationship with them. You know, they're so grateful.
Jackie?
Well, I'm not directly involved with clinical trials patients, but I have my own nurse-led SAC clinic, and it's been running now for about nearly 15 years. So lots of patients would be maybe in long-term daratumumab. I would have patients at all stages, from newly diagnosed with the Dara VTD, maybe some that are second, third, fourth line. So I get to know the patients actually quite well, and I actually have incorporated a bit of support in terms of having a bit of physiotherapy, OT service, a bit of dietetics, social worker involved in the clinic, and use then a tool, the MyPOS questionnaire, just to look at patient issues and evaluate the clinic as well, so that it's meeting patient needs. So managing toxicities, I also would link in then if patients are having complex symptoms with our palliative care team, and have developed good relationship with them as well. So it's building in support, getting to know folks, getting to know what their issues are. Definitely as folks age, get older, they have other comorbidities, their polypharmacy, trying to build in a bit of support, linking in with primary care as well, their GPs and district nursing teams, to build in as much support as is required, because everybody has different needs. So it is assessing the patient and working out a care plan that suits them and meets their needs. But I find it very useful because I've built up a rapport, built up a relationship. I also have a very good link in with the medical team, which the patients then get to know. They get reassured, they can lift the phone, they have my phone number, can leave me messages. So they feel that, you know, there's always somebody there that they can link in with, who link them in with whatever support that they particularly need at the time. So we tend to manage the toxicities much better by managing it that way and utilising the entire team. If a patient comes even to the myeloma treatment clinic and maybe has pain, I can send them off for x-rays. I can link in directly with the orthopedic team. Sometimes we'll see secondary skin cancers, etc. So I've developed links as well with the dermatology team. So it is networking and building in support, and folks get to know your face. You tend to get patients seen in other disciplines much more quickly as well. So it does actually work very well, and it has been well received and well evaluated by the patients and their families.
Excellent. So, Ceri, I think it was mentioned a few minutes ago that usually the patients are highly respectful to the doctor, and they wouldn't really discuss a side effect because they're very grateful. They got the right drug, the best drug, and they're doing well. But then they go next door and see the nurse and start complaining. So how do you handle this from a practical point of view in your clinic? And things may be different, you know, from one place to another.
I mean, I think we can't make excuses and say that's doctor work and that's nurse work. Those days are long over, thank God. We do all have a responsibility to get better at communication and to have the kind of open dialogues with our patients that break down some of those barriers. I can give you an example of a patient that I spoke to on the ward today who's started his second line DVD a few weeks ago. He's been an inpatient on the ward for quite a long time. And actually, I saw him today for the first time in a few weeks. And although we kind of summarized and recapped that his myeloma had relapsed and he'd presented with a fractured humerus and he'd also become thrombocytopenic again, really all he wanted to talk to me about were his family problems and some difficulties that he was having with his wife and his daughters. And he actually said to me, Dr. Bygrave, you're the first person I've told this to. And then it all came out. But actually, I felt humbled that he was able to share that with me. And And also I see that that's entirely my role. So although we have talked a lot about, you know, the things that nurses do really well, I agree with you that developing teams that do this well is also the way forward. But we have a lot to learn from our colleagues for sure. And there will always be some people that feel more comfortable communicating in certain environments than others. And again, truly personalized therapy is one which supports finding that medium for a patient and providing it for them.
Emma, would you like to add something to this?
Yeah, so I'm just trying to think. So thinking of the question that you originally asked, sorry.
Well, this is about, you know, managing the side effect and how the patient would navigate between the nurse and the doctor.
Yeah, so thing is, in our institution, we work so closely together that it's kind of just, it feels like one big team working alongside one another, and literally, Dr. Bygrave is only ever a phone call away, that we can ask her advice or if we need to. We just got a synergy in working together, and the patient, we give them contact details from day one so that they can contact us, so that they can feel safe. Sometimes it's only, you know, just something very, very straightforward that they want to ask, just that they, you know, even dropping a text and, you know, just asking it, can make them feel much more reassured. So yeah, I think, well, we're lucky to have a good connection and a good working relationship that that is beneficial for the patient. So
Great. Let's take a practical example because we have another question from the audience about assessment of frailty. And I think there is a lot of interest these days on adjusting treatment to frailty because we believe that the risk is not only linked to the biology of the disease, but it has also to do with the frailty. So I believe when it comes to assessment of the frailty, there is a need for sort of an orchestra around the patient. So Jackie, how does it work when it comes to assessing the frailty? Because it's crucial to decide on the most appropriate treatment. And some patient may tolerate a quadruplet regimen, others you go to triplet, and even sometimes you go to doublet. And in some cases you say, oh, that's going to be more difficult. Well, what are your thoughts on this frailty assessment?
Well, I have a few thoughts on frailty. I think sometimes it's using our eyes and our ears. Sometimes you can tell just by the way a patient is able or unable to even come down the corridor and into clinic. If they're arriving in a wheelchair whereby they've had other maybe walking aids before, you can see that obviously things have deteriorated. I suppose looking at our more elderly patients, that you can tell that maybe an 80-year-old is quite a good 80-year-old, they're quite sprightly, they tell you about their lives outside of the hospital, and I inquire to see what they are doing and what they enjoy and what their activities are, how often they get out of their home. Do they enjoy going to the theatre? Do they enjoy going to the cinema? Do they go out for meals? So you can do a lot by just general talking. The other thing that I do think is that very useful is to have a tool. And the MyPOS tool is actually very good because while I can definitely converse with patients and have their ear, we can go off on a tangent. They might want to tell you about grandchildren, they want to tell you something about their family life. But the tool can actually pull out detail that you wouldn't necessarily have in a general conversation. And then it gives like a structure to your conversation with the patient as well. So I think both are very useful. And again, even just having access to electronic care records, etc., you can see whether the patient has had maybe falls, who else they're seeing. Are they seeing like a psychogeriatrician? All of those types of things. So it's actually, I think, that in part it's what we see, what we experience, how we assess the patients, that we use a tool, and that we also link in with our colleagues and that there is like a lively discussion, and if someone's mobility has deteriorated, they get physio to assess, maybe having the OT in the community to go out and see they've all the equipment that's required to keep them as independent as possible. So it's a build up of a picture. I think it's not just a simple deciding someone's frail or not, but having a good overall picture of what they're like in terms of how they present themselves in clinic and what their outside activity is like, and working with them and discussing how they are before any decisions are made about a new treatment regime. And I have to say, here in Belfast, I have a great relationship with all of my medical colleagues across the board. It is a very friendly, supportive environment. And I think that the patients can see and sense that and see how we interact with each other and are more comfortable then maybe to share a bit more of themselves with us.
Emma?
Yeah, I just wanted to pick up on the tools. Obviously, we do a lot of quality of life assessment in our clinical trials, and very often we have a tool, and we should do that before we do anything else with the patient for that visit. So that gives us an ideal opportunity to sit with the patient. Very often, if it's an electronic tool, the patients have struggle to use it, or it struggles to work. So it can be an ideal opportunity for us to sit with them and actually go through and pick out those questions. And like Jackie said, they are quite specific questions, but it can be like a basis on which you set the actual visit, because it really does guide you as to how they're coping. Like you say, they like to put on their makeup and put on a brave face and attend clinic like as if nothing's wrong almost. But as soon as you start delving into those questionnaires and helping them with it and sitting through it with them, you do start then to think, right, I think we need to signpost here. Right, I think we need to escalate there. They're really, really important. So again, the importance of quality of life and those type of assessments.
Ceri, would you like to add something?
Yeah, I agree with everything Emma and Jackie have said. Also, I would just like to discuss that frailty is obviously dynamic, and it can change, and the factors that lead to frailty can also be broken down into things that are patient specific, perhaps impacted by, unfortunately, age, but also presence of other comorbidities or previous life experience. But then myeloma is a cancer that makes people frail. And actually, some of the frailest patients that I'm looking after at the moment are in their 50s because they happen to present with really awful spinal disease, de novo. And managing those patients is very challenging. And it's something they have touch points with multiple medical professionals, obviously medics, but nurses, physios, spinal team, palliative care, pain support, all of that, managing them through that journey, those first few months when they are frail, is something that can be really challenging for everyone. Obviously, the UK has sort of led the way in many ways in terms of designing trials specifically for frailer patients. And Mohammed, I'm sure you're aware of Gordon Cook's trial, Myeloma 14 or Fitness, where we're actually looking at frailty adjusted dosing and whether if we actually reduce the doses and allow patients to stay on treatment for longer, we will actually get the same outcome as if we try to hit them with full dose treatment that they then discontinue very quickly and obviously may end up getting less treatment overall. Those types of studies really need answering. To go back to what we talked about in the beginning, myeloma is a chronic disease, and many patients are living with the need to be on treatment for a very long time. So we need to make sure those treatments are given in a tailored fashion. I'd just like to bring up one anecdote that Jackie mentioned it, and you actually mentioned it in one of these webinars many years ago, Mohammed, that I've never forgotten, that actually the most simple frailty score is how does the patient walk into clinic and what is their grip strength like in their handshake. And I totally agree with everyone that often that tells you everything that you need to know. But I also like Jackie's point about what are they able to do? How often do they leave the house? I'm really not a fan of giving treatment that only enables a patient to spend 70% of the day in bed if that's not even quality time and they're not interacting with their family. So these are all really important questions and things that we all need to work together to pull out.
Fantastic. I like it a lot. And by the way, I'd like to thank and commend our UK colleagues, because you're asking some of these very important academic questions, because as we all agree, I think it's not only about bringing new drugs. It's great to bring new drugs, but it's also about giving quality when we extend the life of these patients. So maybe for the last 10 minutes or so of our discussion, because it has been really a lovely discussion, I would like to kindly ask you to share with our audience, because this is a focus about collaboration between nurses and doctors, a couple of examples on real life case on where this close collaboration, cooperation, you believe has made a true big difference, added value, of course, in the course of a given patient. And I don't know who wants to start. Emma, I can see you
Yeah,
smiling.
I
You
can
smile all
share.
the time, but I can see you smiling more.
I can share my example. So, and it's a really simple one, but I think it just demonstrates what we're here to do. So, obviously, I started working in myeloma trials in 2009, and I worked on the myeloma 11 trial. That was my first trial, and that got me into loving the speciality and wanting to do more of it. But one patient of ours who's still on lenalidomide maintenance, after all this time, still in remission, still doing very well. It's a collaborative effort, because she is living her life and doing things in her life that she wouldn't have had the opportunity to do, and she may not have been around, had that trial not existed. And for us to just get a phone call and say, oh, I need my medication by this time because I've got this, that, and the other to do. And we just quickly email one another, right, so and so's in, we need to get this prescribed because she's doing this, that, and the other. And to have that constant month to month collaboration with her to get her sorted, to keep her safe, to keep her in remission is just all that we can ask to do. This is what we're here for our patients to do, is for them to live their lives, and to know that happens is just so satisfying. And that trial has literally transformed a lot of lives, and there's a lot to be grateful for from it.
Very nice. Very, very nice. Thank you for sharing this. Jackie?
All right. I have a patient at the moment who has just moved on to best supportive care. He's early 70s, but in the lead up to stopping his fourth line treatment, he had multiple hospital admissions. In fact, he was spending nearly every other week in hospital with quite serious infections, had a couple of collapses at home. He had developed cardiac issues, and he wanted to continue with treatment because he's a carer for his wife, and he wants to spend as much time with his children and grandchildren as possible. So it was going to be a difficult conversation, because his family were thinking, he's spending most of his time in hospital, what is the point of treatment? And he wasn't ready to let go. So it was a case of his disease was stable-ish, but the really serious progressive infections were actually going to shorten his life, because he was actually becoming very septic with no warning. So that was a discussion between myself and his consultant about how to proceed and how to approach him, to have a discussion about what end of life would look like. It was actually quite moving, because it was very difficult for the patient to accept. And really, it was approaching him in the right manner and together, and having had a conversation beforehand and thrashing out the issues and the risks. And ultimately, between myself and the patient's consultant, we we came to the conclusion that proceeding with more therapy was going to be life-shortening as opposed to anything else. And to get that message across in a compassionate, supportive way to the patient, we worked together on it. And he's now on best supportive care. He skipped into clinic last week. He's so much better off treatment, feeling so much better. He's very aware it won't last, but he's making memories now. He was able to go away for a weekend with his family and really enjoyed it. Brought me back all the pictures. It was a big birthday for him, and he's created memories. He's enjoying his end of life. He's well supported. His pain, other toxicities, other comorbidities are well managed at the moment. He still has a link in and can phone whenever he develops any problems. So that has actually worked out very well, but it was very much a collaboration and working together to support that individual and his family.
Fantastic. This is very emotional. Thank you for sharing this story, and all our best wishes to this patient. Ceri, any case to share with us?
So I think my anecdote wouldn't necessarily be single patient focused, but it's more about the overall benefit that the development of the myeloma CNS and myeloma trial CNS role has brought. And I think it's the ability to innovate. And I honestly think that wouldn't have happened if the profession had been left purely in the hands of medics. So nurses bring new skills and new energy to the arena, and it's an arena where often it's quite hard to find new energy. This job is challenging, but some of my examples, obviously Emma's talked about her own nurse-led research, which has been a huge asset for our department. Our current myeloma CNS is currently doing a master's in pain medicine and wants to set up a nurse-led pain clinic just for patients. Our previous CNS really personalized the role and was pretty much every patient's best friend. And during COVID would actually regularly go around and deliver their oral medication and their food shopping. These ways to innovate, go the extra mile, do things beyond the role is something that I think is really special in the nursing profession, and I see examples of it around me all the time. And everything that Jackie's just described, actually, obviously I don't work directly with Jackie, but I'm really confident and really pleased to see how much this is actually the case wherever we work. It's really good to see.
Well, this is really a fantastic conclusion, actually. Well, we can spend hours actually discussing all of these issues, but I think all three of you have nailed it very nicely, and I'm sure we'll have other activities to continue discussing some of the numerous aspects when it comes. We discuss a little bit about frailty, side effects, but we can dig a little bit deeper about administration, scheduling, psychological impact, how to handle this issue of end of life. I think we have plenty of great topics. Thank you so much for joining today, Emma, Jackie, Ceri. I know it's in a busy clinic day, so thank you for taking the time, and thanks to our audience. Thanks to all those who posted their questions. And if there are any other burning questions, I'm sure you can reach out to Emma, Ceri, and Jackie. But for the time being, I'd like to thank you. And wherever you are, please stay safe and keep well. And see you soon in another ICH activity. Bye.